Well, good evening, everyone. My name is Eric Cohen. I am an oncology nurse. I've been an oncology nurse for close to 25 years at this point. I also have a background in nutrition. I actually have a master's in nutrition and integrative health. And I'll give you a little spoiler. I will tell you that in the future, we will have a talk specifically on nutrition, and hopefully by the end of the year, and then we can come back and do some more of that. I used to work, I'm from Northern Virginia. Before I worked at Puma, I worked in clinical practice at a large health system, a Nova health system, for a group called Life with Cancer, which was very similar to Carolina Breast Friends and the Pink House. And so I did a lot of support groups. I ran a lot of support groups. I spoke at a lot of support groups. So I'm very familiar with this, and I'm really excited to be here. I really want to thank Leslie and all of Carolina Breast Friends for having me here tonight. And I'm just excited to do the talk for you. So with that, I'm going to go ahead and share my screen. And let me go to this view here. Okay, now just give me a thumbs up. It looks good, everybody. Okay, perfect. So I'm really thrilled that we actually are able to come together with women who have HER2 positive breast cancer and speak specifically about HER2 positive breast cancer. I'm sure you all know that there's lots out there for breast cancer, and it's usually like for all breast cancers, right? And not a whole lot specifically on HER2 positive breast cancers. So tonight, the focus is specifically for what I believe most of you have been diagnosed with, okay? And so we're really gonna talk about reducing your risk of recurrence. And I'll explain why that is in a few minutes. So this presentation, this is my disclaimer here, is for educational purposes only. It was developed by Puma Biotechnology. Any questions about specific treatments or your specific plan should be discussed with your physician. So these are the things that we're going to cover today. It won't take very long, actually. And so there should be plenty of time for questions at the end. We're going to do like an overview of HER2 positive breast cancer. We'll talk about how to reduce the risk of recurrence, what treatment plans may look like, and what your role is as a patient in treatment planning, and I'll also give you some resources. I would say that the purpose of this talk tonight is for, what I would really like is for you to walk away from here tonight with maybe a slightly deeper understanding of HER2 positive breast cancer and feel more confident that you can engage in conversations with your healthcare team about, specifically about your HER2 positive diagnosis. So I would love for you to walk away feeling confident, empowered, and ready to ask questions of your team. So let's start with that overview. First, I'm going to give you a little perspective on HER2 positive breast cancer. First of all, in the United States, 1 in 8 women will develop invasive breast cancer, okay? Of those 1 in 8, about 15 to 20% will be diagnosed with something called HER2 positive breast cancer. HER2 positive breast cancer has some characteristics. It means that you have more HER2 cells, HER2 receptors. I'm going to talk more about that in a few slides. But it also means that the cancer grows and divides faster than cancers that are not HER2 positive. And it also means, well, what we know about HER2 positive breast cancer is that about 25% of women who are treated for HER2 positive breast cancer will recur at some point after their initial treatment or their adjuvant treatment. 25% is still way too high, right? I'm sure you all would agree with that. So this is a little bit more in detail on what HER2 positive is. What does that mean exactly? HER2 is a gene, and this gene creates these receptors that sit on the outside of your breast cells. So what you see here in this illustration on the right is that the HER receptors are both on the outside of the cell and on the inside of the cell. It's like a complex, okay? And in someone that has HER2 positive breast cancer, they have way more HER2 receptors on the outside of their cells than someone who does not have HER2 positive breast cancer. So in other words, this is present in normal physiology. Everyone has these HER2 receptors. And let's say, I'm going to make these numbers up, but let's say in a normal person, on each cell, they have 10 receptors, okay, for HER2. In someone with HER2 positive breast cancer, instead of having 10, they have like 1 million. Okay, it's way more. It's not just a little bit more. It's way more than what's normal. And because you have all of those receptors, well, first, before I say that, let me say that in normal physiology, so those HER2 receptors are responsible for cell growth and division. So a protein binds to the HER receptor and it tells the cell to start to divide and grow. When you express so many more HER2 receptors, that's overgrowth, right? And that's what that cancer is. It's overgrowing because of all of those receptors that are expressed on the outside of those cells. So I don't want to beat this over like a dead horse, but it is known to come back, okay? It does come back, we'll leave it there. It can, not always. Good news is, there are specific treatments to treat that receptor, to attack HER2. You're probably already aware of that. We're going to get into more of that in a few minutes. So the most important person in your cancer treatment is probably someone you absolutely never thought of. It's your pathologist, right? And it's the person that you never meet, that's in a lab looking at, with microscopes and looking at cells all day. They really are the most important person, because what they say, what they decide about your tissue is what determines what your treatment will be, right? So that's the most important person. So if you ever get a chance to go to see your pathologist, thank them for getting it right. There are a couple of things that you can learn from your from your pathology report. Two areas really. Your HER2 status and your hormone receptor status. They both start with H, they both sort of start like her, but it's hormone and HER2, and they're both very different. So the HER2 status, it could either be positive, negative, or it could be borderline. If it's borderline, then they will order additional tests to confirm whether or not it's actually positive or negative. Then there's your hormone receptor status, or HR status. And that's what hormones are. It says whether or not basically your cancer is also driven by hormones. And likewise, that it's sensitive to hormone therapies. So her hormone receptor status will be either HR positive or HR negative. And that involves both progesterone and estrogen receptors. And similarly to that HER2 receptor, these are overexpressed on the outside of your cells, these receptors. And there are things that you can take to block that signal so that your the hormone does not drive the cancer either. Okay. Okay. The tests that they do, you may have heard this in, or not. But if you ever do hear these terms, this is what it's referring to, the tests for HER2. It could be either an IHC or immunohistochemistry or a FISH test. We don't really have to get into the details about that, but that's what the tests that they use to determine whether or not you're HER2 positive.
Michael and Maggie have already moved in, but they haven't lived in.
Okay, knowing the specifics of
so
what
maybe we pick a weekend.
what your pathology is really important, because like I said, that's what determines what your treatment plan will be. It determines what options you have to use against the cancer. So why does HER2 positive cancers, why do they tend to come back more than other cancers? Not as well, more often than other breast cancers. So the way we treat the HER2 positive cells is that we attack that HER2 receptor. And you can attack the receptor in two ways. You can attack it either by blocking the outside of the cell. So can you see my pointer if I do this? Right here on the outside of the cell, you could have a drug that binds right in here and stops the signaling pathway down here. You could also block the tumor from the inside of the cell. That would be, it blocks it down here and stops this signaling pathway as well. If you block one pathway, the tumor eventually figures out that there's a way around it and uses the other pathway. That's also sometimes known as resistance. Okay, if a tumor becomes treatment resistant, it means that it's figured out a way around whatever treatment we were using. So if you block the outside, it could start using the inside. If you block just the inside, it could start using the outside. So we're not going to discuss here, but I would like you all to reflect on these two things. Do you know what your HER2 status is? Probably yes, since you're here tonight. And do you also know what your hormone receptor status is? These are important things for you to know when you're having these discussions with your healthcare team. Okay, let's talk about the risk of recurrence. First of all, what is recurrence? What do we mean by that? There are two kinds of recurrence, essentially. One is that the tumor or the cancer has come back locally. And if it's local recurrence, that means it's in the breast or just barely outside the breast. That would be a local recurrence. Or a metastatic recurrence, which means it's now spread to another part of the body. Okay. And when cancer becomes metastatic, it's no longer considered curable. It is treatable. And in breast cancer, it's often very, very manageable for a really long period of time. But it's no longer curable once it's metastatic. Okay? But I say long period of time, and I mean 10 years, right? Or more even. It can be controlled really, really well for a long time. So that's a good part, but it also means it's not going to be curable. Okay. And it's important for you to know that there are treatment options, right? There are treatment options to help prevent recurrence in the first place. Okay. So about 30%, what this is saying is that there's been actually, there's a drug called Herceptin. You're probably all getting it. It's well known, way out there. If you're HER2 positive, you're getting Herceptin. Well, with Herceptin, that's done a tremendous job in improving survival rates, right? So our best therapies, these monoclonal antibodies, the big, large molecules, they have really improved survival rates. That's really important. But it's not zero. In other words, it's not 100% curable all the time. That's why it's important to educate yourself and be able to ask these questions of your healthcare team. All right, let's talk about some of the things you can do, what your treatment plan will look like. So what you're going to see me explain here is what a typical treatment plan could look like. Everybody's is going to be a little bit different, but this is a general treatment plan for HER2 positive breast cancer. And it starts like this. If you have a larger tumor, then today you probably will get something called neoadjuvant therapy. That means, well, first of all, the primary treatment is always surgery. If you can remove it, you remove it, right? You get rid of it. So that's always the primary treatment. And adjuvant really means the second treatment, okay? So there's neoadjuvant, meaning this is treatment before surgery. Some people, if they have a larger tumor, may get chemotherapy before surgery in order to shrink the tumor as small as possible and give the surgeon a better chance of getting all of the disease. So there's neoadjuvant, and then there's surgery. And the goal of surgery is to remove as much of the cancer as you possibly can from everywhere you can possibly see it. After surgery, there's something called adjuvant therapy. That's where you get the chemotherapy, the monoclonal antibodies, the anti-estrogen therapy are all given in the adjuvant setting, meaning after surgery, we don't see any cancer anymore, but we know that there might be some cells that we can't detect. And so adjuvant therapy is used to kill those cells that we couldn't detect with the naked eye, okay? And that helps reduce the risk of recurrence. And today, there's also something called extended adjuvant. That means after the adjuvant therapy, there's also now something that you can do after the adjuvant to further reduce the risk of recurrence, right? So when I said earlier that Herceptin, those monoclonal antibodies have been very, very good, but they haven't eliminated the risk, extended adjuvant is something else to help lower that risk even further, the risk of recurrence. And the way these extended adjuvant therapies work is that they work on the inside of the cell. So we talked about blocking the tumor on the outside of the cell, and now in the extended adjuvant area, you block the tumor on the inside of the cell, which is different, right? It's not the same treatment as the blocking it on the outside of the cell. And it helps prevent that resistance we talked about, where they go around, where the tumors can eventually figure it out. This way, you're attacking both areas. Okay. So what I would say to you is that this is one of the big questions you want to ask your physician is, what can we do to further reduce my risk of recurrence after adjuvant therapy? And the things to reflect on in this section are how many of you are currently, you don't have to answer this to me, but sort of just know, are you on adjuvant therapy now? And do you have a plan for after adjuvant therapy? Has your physician discussed with you what you can do after adjuvant therapy to further reduce your risk? And then this comes down to your participation in your treatment plan. So it's really important for you not to be passive. And I have a feeling that this group probably, because you're here already, you know, in my support groups, they were always the people that were doing the most advocating, and I think that's beautiful. That's what I hope that will help you tonight, is that you've learned a little bit more to help you ask some of these questions of your treatment team, okay? But you want to be an active participant in your treatment plan, okay? The more confident you are about what you've got, the more able you will be to have these discussions with your team. Stick to your prescription regimen. So what they tell you to do, you need to do and you need to complete for the best chance of reducing that risk of recurrence. And then it's important for you to have some conversations with your team about other things, like, from my perspective, nutrition, right? Diet and exercise. What can you do? What shouldn't you do? But what can you do to help reduce the risk of recurrence? I can tell you that what we know scientifically is that one of the drivers of cancer in general, cancer itself, is an inflammatory process. So anything you can do to help reduce inflammation, that means reducing stress as much as possible. It means eating well so that you can reduce the stress on your digestive system, right? So your body can do other things like heal. And it means being active. It doesn't mean being, you know, a bodybuilder or a weightlifter or a marathon runner, but it does mean being active, having some daily activity, right, that gets you up and outside. And it also means sleep, right? And making sure that you are getting really good sleep, because when you sleep, you reduce inflammation. And I know that sleep is, it's not just hard for people with cancer, it's hard for lots of people today, but it's really critical that people get a handle on good sleep. The other thing you want to talk about, always ask about potential side effects, right? Risk versus benefit. And then I would also ask your team, are there any other things you can do to reduce your risk of recurrence? There is a website called reducerecurrence.com. And on that website, you can print off a discussion guide, a recurrence discussion guide. So this will give you, it's a one pager, I believe, but you print it out and it will give you some of the questions we talked about tonight, some of the language to help you talk to your healthcare team about your risk of recurrence specifically. And then there's also a treatment planning guide. So it's got some really good information in there as well. Okay. That's really the bulk of the talk. Now I'm gonna unshare my screen. I'm gonna stop sharing if that's okay, and see if you guys have some questions that we can talk about. And if you do, feel free to unmute yourself and ask away.
So Eric,
Yes.
I had not heard of any extended adjuvant therapy. Is it in the form of a intravenous chemotherapy drug, or is it in a pill form, or what is the actual form of the
It would be an oral therapy. It would be a pill, correct. You are right about that. So currently in the extended adjuvant section, it's a pill. There's a pill.
So how quickly would a survivor go from finishing up their chemo, their adjuvant treatment, before they began the extended adjuvant treatment?
So that's a great question, because after people finish their adjuvant, a lot of times they feel tired, right? or they're exhausted, they've had a long treatment period already. So you certainly can take a break. People can take a break before they start the extended adjuvant. You really want to start on extended adjuvant within the first 6 months of finishing your adjuvant treatment. So whatever your adjuvant treatment is, within the first 6 months gives you the best option, or the best data of success comes from people that started earlier rather than later. But you certainly can take a break. There's no, you certainly can take a month, even a month or two off, and then start the extended adjuvant. But certainly within the first 6 months would be the best, sort of the best thing you could do.
And so would that oral pill be a lifelong?
No, it's 1 year worth of therapy.
Oh, okay.
Yep.
Eric, I have a question about that. I'm an oncology nurse too, and I haven't heard about extended therapy for HER2 positive. Is this relatively new, or have they been offering this for a long time?
So not a long time. It is relatively new. I would say like 2017, right? So the past 5 years, really. But you might hear it referred to as post-adjuvant.
Okay.
So it could be extended, it could be post-adjuvant. Both of those words go hand in hand, but it is a relatively new thing. It's not, it takes a long time for a drug to be out in the marketplace, or drugs in general, to really catch on, right? And be valuable. So be seen as valuable. So it is not new, but it's also not old.
Okay. Well, that's good to know, so that survivors can ask their oncologist about that.
Sure.
I do have two questions on chat that I want to just mention. One is about, and I want to make sure that I answered this correctly. One question was, do you have to be estrogen or progesterone positive to be HER2 positive? And I answered her on chat and said, no, you can be any combination of positive or negative with estrogen, progesterone, or HER2. And I just wanted to make sure that I didn't contradict one of your slides.
Not at all. That is exactly right. So there's HER2 receptors, and there are hormone receptors, and there are different drugs that attack each one of those receptors. If you happen to be hormone receptor positive and HER2 positive, you would get anti-estrogen therapy, and you might get extended adjuvant also, right? The extended adjuvant would be for a year. The estrogen therapy, anti-estrogen therapies would be for longer, right? 5, sometimes 10 years.
Right. And then another lady asked, well, there are a couple more. Are there some supplements recommended to reduce inflammation? And then she said, is that what tamoxifen is? And tamoxifen, I know, is not a supplement, but are there any supplements that that physicians like to recommend to reduce inflammation that you're aware of?
No, I would say that in general, physicians do not recommend supplements during treatment. I'm making a very generalized statement. So you have to ask your particular physician. But in general, they don't really like supplements, right? Because there's not great data on whether or not they're effective. And everything that a physician does is based on clinical data. So I would say it's individual. It's an individualized question for your physician, but and the answer could be, they could go either way. They could say take something, or they could say no, don't take it.
Okay. And then Cassie is asking, are hormone blockers considered the post-treatment? She's taking a blocker while taking her second chemo regimen.
Okay, so also that question about tamoxifen, right? So just to be clear, tamoxifen is an anti-estrogen therapy. So whoever asked that question, that's for your hormone receptor molecule. That's the estrogen therapy. Okay. Now, I'm sorry, just give me that one more time, Leslie. Sorry.
She's asking, are hormone blockers like tamoxifen considered post-treatment? And then she mentions that she's taking a hormone blocker while she's taking her second chemo regimen. And she's triple positive.
Right, she's triple positive. Okay, so hormone blockers are blocking that hormone receptor, but not blocking the HER2 receptor. So for you, the question to the physician will be, is there something I should be taking to block the HER2 receptor to reduce my risk of recurrence? We know that the hormone blocker is also reducing your risk of recurrence, but it's the same as with taking Herceptin, Perjeta, Kadcyla. They are all helping, but they have not eliminated the risk. And so if there's something else you could do, that's the question you want to know. You want the answer to that question.
Hi, Eric. How are you?
Good.
Good. I'm triple positive as well. And I've went through my surgery, chemo, and I'm still doing Herceptin. I'm not done with that until September, but I've also started taking letrozole.
Yep. That's your hormone receptor, right? So that's the HR status, hormone receptor positive.
Okay.
And then on the other side, after you finish, so let's separate the hormone, the anti-estrogen therapies from the chemotherapy or the monoclonal antibodies. So the chemotherapy like TC, right? And then there's the monoclonal antibody like HP, Herceptin, Perjeta. Okay, the TC and the HP, those are all IVs, right? And they're all given as adjuvant therapies. Post-adjuvant, you would do the estrogen. Well, the estrogen you start right away, right? The anti-estrogen. So you're already on that. But then, right? And that yes, and that's going to continue, right?
Yeah.
So in the post-adjuvant setting, though, there's still an opening here, right? The HER2 receptor. And what are we doing about that HER2 receptor post-adjuvant? That's the question.
Is that the question that I will ask my oncologist?
Yes, ma'am. Yeah.
Okay, and that will start the post-adjuvant for the HER2 receptor will start after the Herceptin?
Yep.
Okay.
Herceptin, Perjeta, Kadcyla, whatever. After that's finished, then you would start the extended adjuvant.
Okay.
And you mentioned that was going to be oral.
And that's oral, and that's where you could have that break, right, between finishing the Herceptin stuff and then starting the oral. There could be a break in between. You don't want the break to be too long, but it certainly could be a month or two. If you want just to go on vacation and not have to start something new, that's fine. But those are the discussions you would have with the physician.
Okay, so I just want to be clear. Although I will be taking the letrozole you said is what again? I just want to make sure I have that correctly.
Yeah, that's your hormone, your anti-estrogen therapy. That's blocking the hormone receptor.
Okay, so it's my anti-estrogen receptor, and that's blocking.
It's anti-estrogen therapy.
Oh, anti-estrogen therapy. And you said it was blocking what again?
The hormone receptor.
Okay, so that's the letrozole.
Yep.
So I'm missing the one, which is the extended.
Maybe. Well, so you're going to have this discussion. Yeah. And your doctor may say something different, right?
Right.
So I want to be clear, but yes, that is a question to ask. Yep.
The question to ask is, will I be on any, or is there any extended?
Yes. What are we doing?
Post-ab.
Right. What are we?
Mm-hmm.
Right. What are we doing to protect? Now, really, one of the things you could ask too is, what are we doing to protect my brain? So one of the things that is, happens with HER2 positive breast cancer is that it can go into your brain. So these large molecules, like Herceptin, right? They are large. They don't cross the blood-brain barrier. So is there, that's part of the question. What are we doing to help protect my brain from HER2 positive cancer?
Okay. Thank you. I appreciate that.
Oh, you're very welcome. Other questions?
Eric, can you tell us the name of the oral pill?
Well, I can, because you asked me, I suppose. Are you asking me? Because
I'm asking you, Eric.
Sorry, Leslie. The drug, I was trying to really not, but the drug is called Nerlynx.
Say it again.
Nerlynx, Nerlynx.
Okay.
Yep.
Okay.
You said N-E-R or N-U-R?
N-E-R.
Mm-hmm. L-Y-N-X. Okay.
Exactly.
Do you know what the side effects of that pill is?
Oh, I do, but if there's, so I'm going to leave this up to Leslie for a second.
It's okay. It's okay. It's okay. I love these ladies. I want them to have as much information as they can. And ultimately, it's going to have to be a discussion between them and their doctor.
Absolutely. Yeah. That's right.
Yes, ultimately.
But yes, there is a side effect, and the side effect is very manageable, but there is one, okay? The big one is diarrhea. Now, let me tell you something. We know now how to manage the diarrhea, which we didn't know in 2017. But now we know, and that is, no one starts the medicine at the full dose. You always start at a very low dose and build up. And when you do that, it's really not an issue, okay? But that is where, but there is a side effect, like anything. Now, the other thing is, though, that the side effect is really the first 4 to 6 weeks. Once you get through that first month, you don't have those side effects anymore for the next 11 months, right? And you're so you're good. But the first month, that's where you're going to see the side effect, and that's where you have to go slow. Start low, go slow. So that you remember that if you ever do start a medicine that like this.
Is there any happen? Oh, no.
The other thing I was going to just say, just for full disclosure, Puma Biotechnology, who Eric is with, that's one of their drugs. So I just want to let you know that that he's very familiar with that drug because he works for the pharmaceutical company that makes that drug. Is that correct, Eric?
Yes, that's correct.
Okay, I just wanted to put that out there.
Yep. Thank you, Leslie.
Are there other pharmaceutical companies that make similar post-adjuvant, or are you all the only one?
There's no competition in the extended adjuvant space. There is nothing else. So either you try the Nerlynx, you do the extended adjuvant with Nerlynx, or you don't do anything after your Herceptin progetic Kadcyla.
Okay, Rachel, I'm sorry, I didn't mean to interrupt. Go ahead, please.
No, it's okay. It's okay. I'm trying to stay muted because the TV's on in the background. So I guess, what are the thresholds to qualify either through insurance or with your doctor? Like, are there certain people who would get it, or, do you have to be a certain stage initially?
No, it's early stage. So anyone that is, it's actually indicated in both early stage and metastatic, but it's early stage. So meaning, the main indication is early stage. meaning stage 1, 2, 3, doesn't matter, right?
Okay.
Insurance does cover this. So it's not a burden on the patients. And there isn't really an insurance company that won't pay for it, because the indication by the FDA is for anyone with HER2 positive breast cancer who has received what they call trastuzumab-based therapy, meaning that could be Herceptin, Perjeta, Kadcyla, one of those.
And also, how are there studies to show how much it reduces the risk of recurrence? I don't know if you said that.
Well, no. So if I were to have done a talk tonight specifically on Nerlings, I would show you that that data. It's very strong. It's overall survival data, meaning it doesn't just prevent, the disease from progressing. It actually does prevent, it actually does lengthen survival. That's overall survival. So there is overall survival data, and you can look at that online. Like you can look that up. If you were to go to the website, you would see, they would show you that. And there's a section on the website for patients.
Okay. And then I do have another question about, which is kind of on a tangent, but about like your acidity and alkalinity levels in your body.
Okay. Great question.
And so actually did a foot detox and felt better afterwards. And, in reading about it, the one thing that it said that it could do is adjust your acidity and make you more alkaline. And is that something that really is actually helpful, or what?
Okay, great. Love that question. It's a great question. And it's something that goes around in survivorship circles. You hear this. This is one of the things you hear relatively frequently. So the physiology of your blood chemistry, meaning is it it's your pH level. Is it acidic? Is it alkaline? Is impossible, like virtually impossible to change through water or through food. Anyone that's trying to tell you that it will lower this and that is really just trying to sell you something. Okay. Now, in general, the standard American diet is highly acidic. What that doesn't mean, let me give you an example of something that's acidic. Coffee is acidic, not lemons, right? A lemon is tart and it's an acid, right? But it's not acidic in your body at all. So I don't want there to be any confusion about that. So it's not lemons. Is what we're talking about is coffee, red meat. Those are the big, in the standard American diet. Those are the big drivers of having an overly acidic atmosphere in your body, which what those people are trying to sell you something are saying having that leads to more rates of cancer. Well, eating just red meat and like poorly raised red meat, I have to add, poorly raised red meat and things like coffee all day long, right? Those are not good behaviors. But you can solve that acidity process by not eating processed foods. Stop eating processed foods and try to eat more whole foods, right? And you probably already know that information. Whole food is really the way to go, not processed foods, not ultra processed, somewhat minimally processed, okay. Ultra processed, not so good. That's what makes people more acidic. You avoid those things, you're already reducing your inflammation level. If you eat whole foods, you're reducing your inflammation level all by itself. And your body doesn't need help detoxing. Your liver is the best detox thing in your body. It's the best detox organ, and it is very, very competent. So you just want your liver to work well, and the way to do that is to not overload it with junk food. That's really, I know it's not a sexy answer, but it's the truth.
No, I definitely would rather know. And I'm still trying to get my stomach right. I finished Herceptin in June and I'm still trying to get my stomach right from that. So.
Okay. Okay.
Now,
Yeah.
Soluble fiber. Diet high in soluble things with soluble fiber. Apples,
Okay.
bananas, pears.
Yeah, I was kind of been trying to do like a modified like brat diet.
Well, so that talk that I'm working on to be able to do strictly about nutrition, we'll have a section on that. Stay tuned for that because I'll come back to Leslie. Hopefully October-ish, we'll have it ready. So maybe for Breast Cancer Awareness Month.
Okay. Thank you.
Yep.
yeah, just one last question. Did you say coffee is not good for you, or
A little bit is okay. A little bit is fine, right? But having a gallon of coffee a day, not so good. But a cup or two in the morning, no problem, right? And for most people, they can actually have more even. But if you're like where anything goes wrong is in excess. So lots and lots of coffee, that's quite acidic. If that's really all you're drinking and you're not drinking any water, that's not a good healthful place to be, I would say.
Thank you.
Sure.
I've got some more questions on chat.
Okay.
This survivor says typically she's been told that you don't get a full scan unless you state something hurts or doesn't feel right. And she wants to know if you recommend a yearly exam and how does she make sure the brain is covered to make sure the cancer has not spread?
So that's a great question. And no, not a scan, not more regularly than whatever your doctor is recommending. You definitely don't want to do that. And I would say, you know, in cancer, there are things, and this is true in life, but really in cancer, there are things you can control and there are things that you cannot control. So I think it's really more beneficial to try and focus. I know this is easier said than done, but try to focus on the things you can control and let go of some of the things you can't control. So what the cancer does inside your body, unfortunately, is not something that you have deep control over. But you can control what you feed your body, what the sleep you get, the activity that you do, the stress reduction things you choose to do. Those are things you can control, and those all will impact your health, including your cancer. But in terms of, you know, trying to just do something like earlier scans or whatever to find the cancer earlier, that unfortunately doesn't work, and it has excess risk. There's side effects if you get too many scans. So you don't want to do that either. I hope that makes sense.
I have another question on chat. Lori is asking, are all things caffeinated acidic?
Well, Diet Coke or sodas, not necessarily. Sodas, though, are acidic. Soda in general, so not diet. I was thinking Diet Coke, but it's really all soda. There is in carbonation, there is like an acidic profile there. So excess of that would impact that acidity level. But if you're having an occasional soda, it's not the worst thing in the world. It's not. It's on my bad list, but I also recognize that it's enjoyment for some people, right? They do just enjoy it. And if they want to have it occasionally, okay, that's fine. But to have it all the time, again, it's probably not the best choice.
Ladies, I'm sure there's another question out there.
Hi, this is Susan. Yes, I'd like to ask a question about the effect of sugar on your body. And I know that this might go into the October talk with diet, nutrition, but I'm really concerned about the sugar.
Yep. Okay. So that's also, it's another thing that sort of goes around survivorship circles. And I think you probably get ads pushed to you on by Facebook and other places that may reinforce some of this idea that sugar causes cancer. No, it does not. But any excess refined carbohydrate, so that would be white sugar, white flour, white rice, right? Those in abundance cause your pancreas to create more insulin than necessary. And over time, your body starts to get used to that instead, and that's called becoming insulin resistant, right? So that is not a good place for anybody to be. That causes all kinds of things that you see in our regular out in the world, like obesity and diabetes, all of that, right? High blood pressure or cardiac disease. Very much of that is driven by excess refined carbohydrate. Sugar, occasionally a little bit of sugar is not a problem. If you want to have a donut and really enjoy it. But if someone is that's all they're eating is donuts and Chick-fil-A all day long, right? That's a lot of sugar in the diet, and that is going to drive that poor insulin response. So a little bit is fine. It does not drive your cancer. There's no proof of that whatsoever. But excess is not good for anybody, because it drives inflammation. And what we're trying to do is lower inflammation. Does that make sense to you?
Absolutely. Thank you.
Sure.
I have another question, if you don't mind, if everyone's done. So is there like a certain amount of time, like where if I make it 5 years, or if I make it 10 years, or if I make it 15 years, is there any sort of like exhale point where, if you've made it this far, it really, if you get cancer again, it would be like a total secondary cancer?
I wish the answer to that was yes. To be completely truthful, we really don't know. We don't know when someone, for the majority of people, right? The majority of people, once they get past 5 years, the risk of recurrence or relapse, depending on what disease you're talking about, certainly goes down. It goes down significantly. Does it ever go away completely? I don't think anyone can really answer that ever. And so that's where I think support groups, having people to talk to, because it is something that will always be in the back of your mind. It sucks. Wish you did not have to deal with that anymore. It's not fair. But I think realistically, it always will be somewhere in the back of your mind. And hopefully you can find ways of working through it, but I don't think it will ever be where you can just sort of say you're 100% carefree. I'm not sure. It's like that piece, when you're really young, you're very naive about everything, right? Mm-hmm. That's gone. That's going to be sort of, once you have a cancer diagnosis, it's like, that doesn't really, I don't think that ever comes back.
Yeah. Okay. Thanks.
Sure.
Is it possible to get a copy of your PowerPoint presentation?
Yeah, no, I'm not so sure. I don't think I can, but what you can do is print out from reducerecurrence.com. You can print out the treatment planning guide, and that has all of the questions that we discussed tonight that were in that presentation.
Sounds great. Now, is decaf coffee full of acid, or is it acidic?
Decaf is, yes. I think it's really the same thing. It's it's still there. And Lori, I see your comment that says that it's hard to stay away from sugar. You don't have to never ever have sugar. That is never the case, right? You have to enjoy life and really, enjoy food. I want you to have a good relationship with food. There's no evil food, but overabundance of it is never a good thing. So occasionally, if you want to treat yourself to a dessert, right? Or even if it's nightly, and the last thing you want to have, say before you go to bed, is like a cookie. Okay, that's fine, as long as you aren't wholly subsisting on sugar. Then that's a problem, right? I hope that helps you a little bit. You don't have to be perfect. No one will ever be and have the perfect diet. I don't care who you ask.
Eric, I also see that Kim is asking, she said it's been over a year since her adjuvant therapy. Is it too late to start post-adjuvant therapy? I think
you need, Kim, that's something you can ask the physician, but I believe that you need to have started within the first year, within a year. But I think that's worth asking.
Okay.
Oh, and I see dairy is coming up. So it depends, right? Dairy is not, dairy is not the enemy, but there are a lot of people out there that do have sensitivities to dairy. If you don't have a sensitivity to dairy, then I think you're okay to have some dairy in your diet. You can have cheese, you can have cream occasionally if you want. I'm not opposed to those things. I'm not opposed to dairy. Again, if you're using an overabundance of it, then it's never a good thing. But a little bit is not going to be, unless you have a sensitivity to dairy, it's not going to be terribly harmful. I can really get into more specifics on that when we do that nutrition talk, but it's probably too lengthy to go into tonight. So
I'm excited that you want to do that for us in the fall. I think that's wonderful. Sure.
Thank you.
Ladies, any other questions? You have a captive audience right now with Eric. Anybody?
I have another question. Oh, was somebody else talking?
No, go ahead.
Go ahead.
You said that sometimes it can morph and the Herceptin wouldn't work anymore. Over how much is that, over how long? Like, when does that happen? I'm sure it's not
sometimes it never happens ever, right? So remember I said right now with the current treatment, the current neoadjuvant surgery and adjuvant treatment, survival rates are like at roughly 80% of people will survive and never recover, okay? Mm-hmm. But about 20 to 25%, depending on what studies you're looking at, may recur, okay? So, or do recur, 20 to 25% roughly. So there's a good chance that you will never recur, a very, very good chance. The issue is just that we don't know yet who will be in the 80% and who would be in the 20%. We have no way of knowing that. And so if there was something else you could do, the question to you is, would you want to do it? And that's why I think it's helpful to know this information so that you can make that decision. You may decide, I don't need it, and that's fine. But you may decide, I want to try something else if it gives me another 10%, benefit.
Mm-hmm. Okay.
Yep.
I have a question. Can you hear
Sure.
me?
I can.
Yes.
Okay. I'm in an airport, so excuse me.
Oh,
But
sure.
I wanted to find out, I'm approaching 10 years on tamoxifen and will need to come off of that. And I am HER2 positive, progesterone positive, estrogen positive, progesterone negative. What would you suggest is a next treatment? Are there other options that you're finding at these 10 years out? What's going to happen? What do you recommend?
No, now I think you're good. Like, hopefully you're the one in that 80% and you're going to do really, 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 really well. That's that point about the things we can control and the things we can't control, right? So you've done really, really well. And that's where I want you to sort of be tonight. That you did really, really well. At the moment, there isn't a next step, but also you may never need a next step. And so I hope you can find some peace in not having any treatment on board.
I feel like my security blanket's being taken away from me soon.
I get it.
Yeah. And you wouldn't push for 11 years on tamoxifen,
Nope.
Even though it's
Absolutely.
no?
Absolutely not. No. No, because that's where the data, that's where the doctors are really driven by the data. Right? If there were good data to show that longer period of time, I'm sure they would do it, but there isn't. So that's what you stick to.
Okay, thank you.
You're welcome.
And Leanne, a doctor came and talked to us at the Pink House a couple of weeks ago. It was Dr. Hazakadak, a breast surgeon. And she was just talking about how, when you do go to year checkups or you do give up a medicine and you do feel like your security blanket is taken away, the doctor said that you can call them and make more frequent appointments as you're making that transition. If it makes you feel better, you don't have to wait 6 months. You don't have to wait a year for your annual checkup with your oncologist. If you want to go see your oncologist 3 months after you finished your tamoxifen, just for your own peace of mind, then do it. And that gives you a little bit of your security blanket back. And Dr. Hazakadak was the one who said that. So, I just wanted to share that with you.
Thank you. That's good to know. I appreciate that.
Absolutely. Eric, it looks like we've got a couple more questions. Rachel is telling Lori that she has a chocolate flavored calcium chew that will help with the sugar fix at nighttime.
Nice.
So, so you all can, Lori, if you want to email me, I think everybody has my email address. I can get that information from Rachel. And then Cassie is saying, how is it determined if we are becoming resistant to a drug?
Yeah, it's not. So again, 80% of people will do really, really well and not become resistant, and 20% of people, will have a recurrence. So right now, you want to operate from the position that you're in that 80%. You are in that 80%. That's how you want to think, but you also want to be good to your body and do the things that you need to do things like reducing inflammation, your stress level, and improving your sleep, and eating well. So you want to do all of those things because it's healthful. And now, because you had a diagnosis of cancer, more than the average person, you really want to invest in your health, right? And so those are the things you can control, and those are the things you can do. The cancer, what the cancer does, we can't control, and that's why there is no test for that. We don't know until you've recurred. You will not know, and most likely you'll be in that 80%. So stick to that place, but still do the things that you can do to reduce your risk, right? Leanne?
one more question. So you're not a big coffee fan, and I
I'm not. No. I'm not a coffee. I have coffee every morning. I love coffee, but a little coffee as opposed to a gallon. People that can't live with anything, they can't drink anything else but coffee. That's not a good.
Like 2 cups.
2 cups, fine.
Okay. Would you prefer to? Would you prefer to see that?
Amounts.
Okay, good. Would you prefer to see any of that be green tea, or is that just as acidic?
No, I think if you like coffee, having a couple of cups of coffee is great. That's fine.
Okay.
Really, we're talking about people that's all they drink. They don't get in any other water. They either get in coffee or they get in Diet Coke. That's not a good thing.
Are you a big fan of green tea?
I think I'm not a fan. I'm not. I don't think that there's that it's a cure-all for anything, but I think it's tasty, and I think every good nutrient out there offers some benefit to the body. Every one. So green tea does have some important health benefits to the body. If you never drank it, you still could get those benefits from other things. But if you like it, it's good.
Thank you.
Sure.
Another survivor is asking, how can we sense if we are beginning to cause too much inflammation?
Well, okay, I like that question. I have to think about it for a second. If you feel, I think it's important to sort of maybe it's nice if you can do like a health inventory on yourself from time to time. How are you feeling in your body? Do you feel well? Do you feel rested? Do you feel uncomfortable? Do you have significant pain anywhere, like joint pain or back aches or headaches? Do you have things that are making you uncomfortable in some way? What I would say to you and to everyone tonight is that it would be really helpful for you is to try and think about any symptoms that you ever have in your life as teachers rather than as problems. So a symptom, like say a headache. You have a headache. Instead of saying this headache is just a problem and take Tylenol to make it go away, think about what is different over the past 24 to 48 hours. Did I eat anything differently? Did I sleep differently? Is there a stressor going on? Anything different over the past 24 to 48 hours that might have led to the development of that symptom, which is in this case the headache, right? It's really nice to start thinking that way as opposed to this is a problem, because all of our symptoms are teachers in some way. Is it something I ate? Is it some way I slept? Is there more stress in my life? Usually, unless someone has like chronic headaches and really, needs help. But we all get headaches occasionally, right? But those kinds of symptoms, do a health inventory, feel it. If you have shoulder pain, why am I having shoulder pain right now? Is it an injury, or did I eat something that is causing more inflammation in my body? Think about it that way. Lori, I see your question about health inventory questions. I will, when I come back and we do a nutrition thing, we can talk more about that too, I think. But I think just asking yourself, like I said, what is this symptom teaching me in this particular moment, right? If I have a headache or an ache or a pain, did I do something over the past 24 to 48 hours that might have contributed to this? Maybe you won't find anything, but maybe over time you'll see a pattern developing. Oh, I had white bread, and lately white bread is causing me to have some GI discomfort, something like that. that's what you want to pay attention to.
Eric, I'm very hesitant about taking vitamins. I take my calcium pills, I take my vitamin D3, but when I was going through my treatment, it was said not to take vitamins and things of that nature. So I'm done with the chemo. I'm still doing Herceptin, but I'm still a little leery about taking vitamins because I'm triple positive. But I wanted to know about what can I do to get my energy level back, because I feel like, I get tired easy now, or a little quicker than normal. So
vitamins are not, they're not particularly helpful, to be perfectly honest, because I think that you should think of food, whole food, as a delivery system for the nutrients. So a carrot, right, is not just beta carotene or vitamin A, right? A carrot is an entire delivery system to get you the nutrients, beta carotene, vitamin A, in your body. If you just isolate vitamin A and take it, there's no delivery system there. And most of the time, it's not absorbed very well. If you eat carrots, you get plenty of vitamin A, right?
Mm-hmm.
So you want to think of whole food as really the delivery system for all of those nutrients, and always go with whole food first.
Okay.
One of the things I would say, so fatigue is very common for people being treated with cancer. So it's very possible that all of your treatments that you have been through have just contributed to this fatigue or made this fatigue for you, okay? It's also possible, believe it or not, I don't know what your diet is like, but it's possible that you're not getting enough energy through your food. Most people today, if anyone, not most people, but I will say this, if anyone has ever been in a place where they can't lose weight, they really have tried everything they could possibly do to lose weight, usually the answer is that you're not eating enough food. It's not what you think it is, that I'm eating too much. When you're not eating enough food, your body downregulates every process in your body. It gets used to the fact that there's no food coming in, and it starts to conserve everything. And so you hold on to everything and you just don't lose weight, for instance. The minute people start to eat what they really need to really get 2,000 calories a day-ish, depending on the person, right? They start to feel more energetic, they can be more active, and then they naturally start to lose weight, believe it or not. It's not all about calorie deficit. Like anybody that's telling you it's all about calories in, calories out is not telling you the whole story. You probably don't understand the whole story.
So just make sure you're eating the whole foods that give you, like they say, vitamin B gives you energy, but eat more food that contains that to get your energy, or things that, okay.
Yep. It's a really good Mediterranean diet, right? Good amounts of fish and seafood and some meat and a little dairy and lots of vegetables, lots of fruit, right?
Mm-hmm.
Those things will really reduce your inflammation level, make you feel good, give you energy, but you have to get enough of it in. That's the other part of it.
Yes, thank you. I appreciate
Sure.
that.
Let me see this. Says something about my fitness pal to track my food. It's been helpful in teaching me what I'm truly eating. Yes, that is exactly right. I love that. I think that's great. Sometimes tracking can be really helpful for people, just long enough to teach them what it feels like and what it looks like to get in enough food and the right foods. And then the question from Rachel about protein shakes. Are they good? One protein shake a day, great. Rest of your protein needs to come from real whole food. But one protein shake, especially if you're depleted, when you're going through chemotherapy, your body is depleted. We're rapidly breaking down cells, right? You need protein to rebuild those cells. and a protein shake can be very, very helpful.
Okay, but like a protein shake and a protein bar is
too much. Right. It's like you want to get most of it from whole food, real food, the protein. But like an occasional shake or bar is fine.
Okay. Yeah, I'm not a big meat eater, so I do legumes and stuff, but it's hard to always. I feel like I need a lot of protein right now, so.
Yeah. So using the shake is great.
Okay.
Yep.
Thanks.
I have a quick question. I love to eat salmon, and I eat it all the time, maybe 4 or 5 times a week. Can you eat too much salmon?
I don't think so. But I hope I don't ruin something for you. Here's the thing. There's a big difference between Atlantic or farm-raised salmon and wild-caught salmon. A big difference. The difference is that farm-raised salmon, or any Atlantic salmon is farm-raised, is fed corn. Corn is an omega-6 fatty acid, okay? Wild salmon, when it's in the wild, eating what it would normally eat in the wild, is omega-3 heavy, right? So wild salmon is really, really good because it's very heavy in omega-3. Omega-6 is not bad, but in the standard American diet, we eat too much omega-6 and it throws off our balance of omega-3 to omega-6. Most people don't eat salmon in the United States, I would say, probably most people don't, or at least enough. And so their ratio between omega-3 and omega-6 is lopsided. If they eat salmon, they're eating Atlantic salmon, it's very omega-6 heavy. They don't get a lot of wild salmon, they're very low in omega-3s. And you want both in your body, but you want a good ratio, 1 to 2. 1 omega-3 for every 2 omega-6. I don't want to get too in the weeds here with this, but just to let you know, omega-3 is anti-inflammatory, omega-6 is pro-inflammatory. If you have too much omega-6, you can't turn off the inflammation, which is the job of omega-3. It turns off inflammation. So people say, take an omega-3 supplement. But the real issue is eating too much omega-6. So yes, an omega-3 supplement can be helpful, but omega-6 is the problem. Got to stop eating the corn. Where does the corn come from? Salmon and all farm-raised animals. Chicken, pork, beef, all of those animals that are farm-raised are being fed corn, which is omega-6. That's not a good thing. Okay. That's why the whole grass-fed thing is an issue. But look, that can be a cost issue for people, and I don't want that to get in the way. So if it's a choice between eating Atlantic salmon or no salmon, eat the Atlantic salmon because you're going to get some omega-3 benefit from it. But if you have access to wild-caught salmon, go with the wild-caught salmon.
And is wild-caught always the really orange salmon?
Not always. It's just, it has to say wild-caught or Alaskan. Anything Atlantic is farm-raised. It's just the way laws, and it's just the way it works. But Pacific salmon is wild-caught. It will usually say wild-caught salmon.
And it can have a different flavor from the farm-raised.
It can, because you're tasting the corn, believe it or not.
Yeah.
And,
okay.
Leslie, I buy the frozen fillets, the wild salmon at Harris Teeter. They have like 2 fillets to a bag, and it's pretty good with sauces or seasoned or by itself.
Okay.
Real easy to prepare. It's quick to eat, and I love salmon too.
I do too. I could eat it every night. Okay, good to know. Thank you.
Sure.